So as Chet noted, this presentation is really the first step to help ensure that we all have a shared understanding of publicly available data. There's a lot of different data sets, and these will serve as the foundation for our future development of a collaborative oversight and monitoring plan in order to track key outcomes and identify and address challenges and ensure accountability. So as Chet noted, there's no action for today around this, but our aim is really to learn about all of the available data, what it can tell us, and inform areas that we'd like to prioritize for monitoring in the future. So to lead us through this discussion, we have Sarah Brooks, who's a director at Sellers Dorsey and was recently the Deputy Director of Healthcare Delivery Systems with DHCS, where she oversaw managed care quality and monitoring, managed care operations, and integrated systems of care. She was with DHCS for nearly 7 years, managed the entire Medi-Cal managed care delivery system, which served 10.5 million beneficiaries. And her areas of expertise include network adequacy, quality, member rights, contract management, and provider and encounter data, all of which are very important focus areas for the work of this commission. With that, Sarah, thanks so much for joining us, and I'll pass it off to you.
Thanks, Janine. So good afternoon, everyone. I appreciate you all obviously joining the meeting, but I know we're late in the day here, and we're going to talk a little bit about data, which is exciting. Let's get excited about data. So I am going to share my screen here. All right, I hope. And all right, can you guys see my screen? If you can shake your head. Yes. All right. Of course, all right. So as Janine talked about, just a little bit of background about myself, she kind of laid it out there, but I did work at DHCS for a period of time, was responsible for working with and overseeing the Medi-Cal managed care plans, and so became intricately knowledgeable about kind of just all the different data points and data sets that are out there when it comes to managed care. And we'll talk a little bit about this in the coming slides, but what you'll see is that there is a lot of data. And there's a lot more data that could be shared potentially. And so, so we'll have some conversation about that today as well. So just a little bit of background. And I think I looked at who's on the screen or who's on the Brady Bunch screen today. And I see that there are a number of people that I know. And so I know that many of you have a lot of this background, but I think this is really a good opportunity for us to lay the groundwork and make sure that we're all on the same page and we all have the same information. So for some of you, please feel free to kind of jump in if you have questions or comments at any point or any time. And I don't know if I'll be able to see the hand holding or the hand. Janine, if you can let me know, that would be great. So a little bit of background. I think both of you know that, or most of you know, not both of you, most of you know that DHCS and DMHC, so the Department of Healthcare Services and the Department of Managed Healthcare, are generally responsible for overseeing the Medi-Cal managed care plans in California. So you'll hear me call those MCPs, or you'll see them on the slide here, MCPs, when I discuss them. DHCS is really more a purchaser of services. They do contract with the to cover services for Medi-Cal beneficiaries, as you know. There are 24 primary plans in the state, 5 of which operate in Sacramento County. And DMHC is more of a regulator. They assure compliance with the Knox-Keene Act of 1975. And most MCPs are Knox-Keene licensed. I think, what we talked about already is that both departments collect significant amounts and types of data from the plans. They're really used in different ways for monitoring and oversight, but also just for understanding what's happening. The data can be used as indicators. We'll talk a little bit about that in terms of identifying places where you need to look a little closer to identify if there is an area of concern. And so we'll walk through today during this presentation, these data, just flagging that these are really non-financial data. There are some data related to medical loss ratio and other kind of financial pieces that we could discuss on a different day if that made sense. So the first couple of slides that you'll see here talk about the different types of data that I'm going to go through in the presentation. And you'll see that there's a key here. So in black or in bold, these are data that are currently available at the plan level. Demographic, or excuse me, those in blue, for example, demographic on the slide here, are not public at this time, but they could be made available. So I think that's something that might want to be discussed with the state or internally here with your commission as to whether or not you might want to request it. And then for red, these are data that are not provided at the Sacramento plan level. Again, though, could be discussed for purposes of talking with the state about whether or not this information could be made available. So you'll see that I've broken it into different types of data. So we have Medi-Cal enrollment to start and encounter data. So these are kind of like what you traditionally think of as data, right? They're data, numbers, right? Then we have beneficiary satisfaction information and data. So we'll go through those. And then finally, access to care. So those are the different kind of categories that we'll discuss today. So starting with Medi-Cal enrollment, I think you guys are familiar with this information. You have over or close to 600,000 Medi-Cal certified eligibles for Medi-Cal in Sacramento County, and about 500,000 of those are in a health plan. And so you can see the breakout here. And this obviously is data that is available. But I think what's important to note is that it's really available at this aggregated level, right? It's not to us in a breakout demographically. So we're not able to see ethnicity, language, gender, age, or anything of that sort. And so I think this is an example of a place where you could potentially have further conversations with the state about what data they include on their open data portal and how it can be provided so that there can be further analysis and understanding of who's actually receiving services and care in Sacramento County. So encounter data. So what's an encounter? I think most of you probably know this, but I will talk about that real briefly. An encounter is really, when you go to the doctor's office, it's everything that happens. It's the visit itself. It's, did you get a vaccination? Was there some kind of screening done? So everything is coded into different codes that are submitted with this encounter, and that data is submitted to the state. And so you'll see that the state itself does collect the data and monitors the data that are submitted to them. And then they use that data to calculate different metrics. And we'll look at those for a minute here. So starting out with the kind of encounter complete, DHCS does have what's called the quality measures for encounter data. That is a set of about 30 measures that they use to look at encounter data to see if those data are complete, accurate, reasonable, and if they're submitted timely. So what they're really looking for is the data usable, right? Because if it's not good data, it's not going to tell you what's actually happening within the Medi-Cal program. It's not going to tell the true story, and so it's not truly usable. So they're definitely wanting to monitor whether or not those data do fall into what I call the CART, complete, accurate, reasonable, timely. The reason it's important, again, that they have those data and they are good data, good clean data, is because they're looking at utilization factors. And so in this instance, you'll see a list of metrics that are included on the screen here. These data are reported in the quarterly managed care performance dashboard. Most of you are probably familiar with the dashboard, but it's quarterly issued by the department. It includes a number of different data about managed care plans. A lot of it is in the aggregate level, so it may not be broken out by county. Some of it is broken out by county, some of it's broken out by plan, but it's a good resource and a place to go. You'll see it's linked here at the bottom of the screen to identify information about how plans are performing. But I think what's important to note is that these metrics are kind of standard metrics that are utilized for looking at how health plans are performing. And so if you could get more granular with these metrics and look at what's happening in Sacramento County specifically, even with a health plan specifically in Sacramento County, it would provide you with more of a basis of understanding, are emergency room visits high, inpatient admissions high? I mean, I think we know because of COVID, things are high right now, but are things abnormally high, I guess is what I'm looking for. Or are people accessing care through primary care, or accessing their care through outpatient visits and seeking primary care as opposed to going to the emergency room, for example? All right. So then a big piece of kind of what you really need to consider, and I think I heard this, Lisa talked about this before and Siobhan did as well, beneficiary satisfaction, right? So it's about knowing who and what the experience of the beneficiary is when they're actually accessing care. Are they getting good quality care? And what are the different indicators and data that are out there that will tell us, will tell that story to us? And so this is a list of kind of the things that I'm going to go through really quickly with you all, and obviously welcome any questions or comments. So the CAPS survey, many of you are probably familiar with what is called CAPS, or the Consumer Assessment of Healthcare Providers and Systems Health Plan Survey. That's why I'll call it CAPS. So it's actually conducted by the department. They do it every 2 years. It's known as the External Quality Review Organization, or the EQRO, also known as HSAG, Health Services Advisory Group. That's the actual company that does the work. They actually survey every 2 years, and they survey beneficiaries and members of health plans to actually get the experience that I was talking about. So as I mentioned, the goal of the CAPS survey is to really kind of gather information from members. And this is really the one place where you get the members' true voice. It's not through a complaint. It's not through some other kind of thing that's just collecting data. This is really responses to a survey from beneficiaries, so it's important. What's complicated about it is that the response rates have historically been low in comparison to national averages, and there are small denominators. And so what that means is that generally you want to have a denominator of more than 30 respondents for the survey in a geographic area where a health plan is operating, to be able to report out on how they perform. And when you don't, then you end up with this situation where it's not applicable, not applicable, not applicable. If you look in the CAPS report that's linked at the bottom of this slide here, you'll see Sacramento County oftentimes, and I think almost always, if not always, there isn't data reported because the denominator is so small. And so while CAPS data is available, and you could look to get further information potentially from the state on these data for Sacramento County specifically, there are some complications around the data itself. And then the table that's on the slide here just looks at what data are actually collected through CAPS. So they're looking at overall global ratings in terms of the health plan, the healthcare, the personal doctor, and then composite measures in terms of how quickly your care, did you get the care that you needed, how well did your doctors communicate with you, and so forth. Grievances and appeals is another place where you might see data show up. So this is like an example of a grievance is somebody hung up on you or was mean to you, and so you want to file a complaint about that. An appeal is really more like a denial of a service. DHCS does collect quarterly data from the health plans at a beneficiary specific level. So they're actually collecting for every member that files a grievance or an appeal, who the individual was, they'll have all of their data in terms of race, ethnicity, gender, and so on. And then what the reason for the complaint being filed was. And so DHCS is able to kind of navigate and look at this data. And this is a kind of beginning spot of where you see that you can use data as an indicator for identifying where there might be a problem. So an example might be that you delve in Sacramento County and see that for African Americans, there is a high complaint around children with, I'm just making this up right now, but children with autism that are not receiving behavioral health treatment. So you see that that's an area that you perhaps as a state need to then look at with the health plans to identify, are all the health plans experiencing this issue? Is it just one health plan? Is it related to just one IPA within a health plan? So it's really dissecting and looking at where does the problem exist if it does, and then identifying what the corrective action is so that you can ameliorate the issue. So these data are also reported in the managed care quarterly performance dashboard, and so you can go there to find out further information about them. Let me pause and just see if there are questions. I don't think so, but I know I'm talking a lot about data and no questions yet. Okay. So state fair hearings. So everyone has a right to a state fair hearing, but to get to the state fair hearing process, you do have to go through the process that your MCP has for grievances and appeals first. These data tell you, again, this is an indicator kind of place where you might identify, for example, when I was deputy director, we did identify that there was a high prevalence of state fair hearings being filed for individuals who were trying to obtain wheelchairs. And that's obviously not a good thing. But it allowed us to identify that there was an issue, and then to revise the policy and work with the plans to implement that new policy so that people did have appropriate access. So that was an example of a state fair hearing kind of concept that came out of the filings of the hearings and the data that was reported within them. These data are reported to the health plans quarterly by the state. They're actually broken out. They come from the Department of Social Services. They're broken out and reported to the state. They're reported to the plans on an individual plan level. So this could be data that you could obtain. They're also reported in aggregate in that managed care dashboard that I mentioned before. So IMRs are kind of the sister to state fair hearings. These are done by the Department of Managed Healthcare. This is essentially an individual kind of independent clinical review of an appeal for services. So it's, you know, if you have a complaint because you didn't receive a service, you're going to file an IMR, and a independent group of clinicians is going to look at it and determine whether or not you should receive the service or not. Again, these are data that are indicator data that tell you you should look at a specific area because maybe you're getting a high number filed in some area, like behavioral health treatment or something of that sort. And these data are provided to the health plans quarterly, so they are aware of kind of their performance and how many IMRs are being filed on their behalf. Call center data, again, within beneficiary satisfaction. So the requirement is actually that plans have to answer within 10 minutes, and that's tied to the standard that is out in the regular community when you would call any health plan or call your telephone provider or anything of that sort. But these data are collected from the health plan or from the health plans by the state, not reported today publicly, but I think will be in the near future. And so opportunities here to gather information about how long people are actually waiting to get through if they need help. And that's obviously important, because how long will somebody stay on hold if they are seeking care is an important question. The ombudsman. So the ombudsman is essentially I mean, it's listed here. It's a government agency to whom people can go for assistance with navigating the programs or policies of the agency. This is supposed to be an independent kind of entity or person that you can call to get help. The Department of Healthcare Services does operate an ombudsman that represents the Medi-Cal managed care and the mental health components. And these data are reported quarterly to the managed care advisory group. The data themselves are broken out by health plan. And so this is a good place where, again, you can look for indicator data to identify if there are a high number of calls coming into the call center for the ombudsman that may be tied to some sort of service that's not being received, or language access being an area of concern or something of that sort.
Sure, there's a bunch of stuff. It's a little cold outside.
So I think, as I mentioned, you know, these data as a whole provide an understanding of kind of beneficiary satisfaction. The point or purpose is to look at the data together and understand kind of what the story is that's being told, as opposed to individually. But I think what you see is that they're limited in terms of what kind of information are available. And so there's some further exploration that can be done to better identify opportunities to understand beneficiary satisfaction. So quality, before I go into quality, any questions or comments? Okay.
I see one question in the chat. Maybe.
Oh, perfect.
Janine,
I can't see it. Can you read it to me? I'm sorry.
Sure. It's from Deborah Payne. She
Hi,
asks,
Deborah.
how will additional data be requested through PRA? Will there be a cost, or can the health authority request directly from DHCS?
So it's a good question, Deborah. I think that would be a conversation that the commission would have likely first with the department to see what kind of data might be made available or could be made available. or a Public Records Act request is a way that you can get data, but I don't know that it's the most direct or easiest route when I think as a county, Sacramento is looking to have data on a regular basis that can inform the monitoring and oversight of the health plans. But I think further discussion would probably have to be had by you all to decide how you want to approach the department on that. And others may want to speak to that.
Thank you, Sarah. We requested data specific to Medi-Cal managed care dental, and then the answer, and spoken directly with DHCS, and the answer is you have to submit it through PRA and that there may be a cost. I just want to give a heads up to everyone that that may be the answer. Hopefully not, but wanted to put it out there.
I agree, and I understand that. I think I guess what I would say is I think there's opportunity to potentially partner with the department on things, but you're right that if you need data specifically from the department, a Public Record Act request needs to be made. And if it's not data that they have readily available, like a report or something, then a cost can be associated with collecting that data. That's correct. So in terms of quality, we'll start by just talking a little bit about the managed care accountability set, which was recently or previously known as the external accountability set. What happened essentially was that a few years ago, DHCS aligned its required measures for health plans. So these are like HEDIS measures that are submitted by health plans in terms of what their performance is to determine how they are doing on quality. DHCS previously had kind of a list, which was called the external accountability set, that was comprised of measures that were chosen largely by DHCS, had input from health plans, stakeholders, advocates, providers, and others, but then moved to aligning with what's called the CMS core measure set. And this is a measure set of about 60 measures in total. If you look at the measures, though, you'll see that not all of them are those that are applicable to health plans or MCP specifically. As you know, the delivery system in California has many different carve-outs, for example, behavioral health. And so you'll see that some metrics that are specific to health, which are CMS core measures, are not tied to the MCPs in terms of requirements for reporting. Those measures are either reported by the mental health plans or not reported at all by a delivery system within the state. I think an example of that, just to give you, is with the upcoming carve out of Medi-Cal Rx, all of the different pharmacy measures that are included in the CMS core measure set that are also on the managed care accountability set will no longer be in place because the plans won't be responsible any longer for that provision of services. So in terms of what the data themselves tell us, they really tell us how the plans are performing on each of the managed care accountability sets. So what happens is that each year that ECRO that I talked about goes out and they audit the health plans. They pull data for this core set of measures, which is the managed care accountability set, and they look at the prior year's reporting year. So they're using the prior calendar year's worth of data, and they're determining how did the health plans perform. So what was the rate of performance in terms, did the health plan a certain criteria, a threshold percentage for performance on the specific measures. All of the measures, not all of them, I'm sorry, some of the measures have a minimum performance level. That's 50% of the national average of Medicaid health plans. But when you look at the list of all of the managed set measures, you see that probably about 15 of them are held to a minimum performance level, and another probably 20 are not. And the reasons behind not holding them to a minimum performance level may be that there's no benchmark available, it's a new measure, or denominators are too small, and so it's not possible. An example of a measure that's reported now is what we call CIS-10, or the Childhood Immunization Status Combination 10. So that's immunizations for kids. And so what they're looking at there is how did the health plan perform in terms of overall rate? And if they hit 50% of the national average, then they have met the minimum performance level. If they do not, then they have not met that performance level, and the state may take corrective action measures against them as a result of that. I think you've seen the different kind of domains that are listed. I know that Janine's provided you all with a document that includes all these different measures, so I won't go through them. But what you can see is that from the managed care accountability set, as I mentioned, there are 36 measures, I think there. Those can get broken down into different indicators. So there are additional kind of measures that can be broken out. So an example of that might be here where you see HIV viral load suppression. They're broken out into 2 different age groups. If you look at the MCAS or the managed care accountability set, you'll just see one measure listed. But if you look here, you see that it's broken out into 2 different age groups. And so there are different domains with different measures and indicators that are reported in the health plans. And then the other 2, children's health and women's health being the other 2 domains. The aggregated quality factor score. So this was something that I was interested in when I was at the department. I just wanted to know how plans were performing overall on all of their measures. And so what this does is it looks at the managed care accountability set. And for those measures that the health plans are held to a minimum performance level on, it looks at how the health plan performs in the operating area that it operates in. So for example, in Sacramento County, we're going to look at Anthem Blue Cross, and we're going to see that they met all of their, or 75% of the measures on MCAS, they hit the minimum performance level. And so their score would be 75%. That's just an example and not anything real, just to be clear. But then you're going to be able to look at how that health plan then compares to the other 4 plans that operate in Sacramento County with respect to how they perform overall on the different HEDIS measures and what their minimum performance levels are and if they met them or not. So it's really a way of looking at kind of how the plans overall perform across the board and compare to each other in the state with respect to overall quality on the managed care accountability set. I think many of you have seen the health disparities report. This report further stratifies certain managed care accountability set measures by different demographics. It may be by race, ethnicity, gender, age, language, geographic area. It's looking by MCP and operating area to see what performance is. So this is again another way where you can look and dive into the data to see. If you look at the data in aggregate, it may appear that there's no disparity, but if you dive in, you may see that, for example, African-American Black women have been found to have significantly lower postpartum service rates. So it's just a good opportunity or way to understand that if you further stratify the data, it will tell you more about where the disparities are. And these data are currently reported at the MCP aggregate level in the health disparities report. An example from the disparities report, I'll click past that. So performance improvement projects, so PIPs, they also have been known as quality improvement projects in the past. We like to change acronyms. I think that's always fun. MCPs are required to participate in a minimum of 2 PIPs annually, and the PIPs generally focus on an issue in a population. So for example, focusing on lowering HbA1c for Latina women. PIPs include something called Plan, Do, Study, Act. So this is like planning for what you're going to do. You actually do it, you study, did it work, and then you act on what the results are, and you keep cycling through that. And these are opportunities for plans to identify best practices and spread best practices within their delivery systems based on those PDSA cycles. I think also important to note that when plans are under corrective action plans for quality, PIPs are often used for looking at opportunities for creating improvement and strengthening overall performance of the plans. think we're getting close to the end of quality. On preventative services, so many of you may have seen, this is a new report that came out. It's the 2020 Preventative Services Report, reflects data that were collected in 2019. I'll show you the measures. I believe I have them listed here. So you'll see here the different measures that are included in the Preventative Services Report, including chlamydia screening in women, developmental screening in the first 3 years of life, child and adolescent well care visits, and so on. Dental fluoride varnish. An addendum was issued tied to blood lead screening, and you'll see that there were that were included in that addendum that are listed here, that were specific to blood lead screening, as I said. And that was really, I think, the result of an audit that came out from the California State Auditor's Office and a response that the state engaged in terms of action in response to the findings. So before I move on to access to care, again, I will pause because I'm doing a lot of talking just to see if there's any questions or comments. Looks like no. I will keep on going then. We're tracking through here. I appreciate you guys sticking with me here. So access to care. I wanted to talk a little bit about just the process for DHCS MCP monitoring and oversight and what happens. I'm sorry. I wanted to talk first about the network adequacy certification and then tie in there the managed care monitoring and oversight component. So DHCS does annually review and certify each MCP's network for the Centers for Medicare and Medicaid Services, or CMS. And they do look at the data by a granular data. So they're looking at the granular level by zip code to determine if providers are available to plan or to members or not. They are then scoring the plans on 4 different criteria, and you'll see those listed here, which is you pass, you have an alternative access standards pass, you pass with conditions, or you're non-compliant. Generally, I think what you'll find in the certifications a lot of the time is pass with conditions. And really what that means is that the plans have been placed under a corrective action plan until they can come into compliance with what the requirements are of the certification. And usually that lasts for about 6 months when the plans are working with the department on rectifying any issues where they're not in compliance with the network adequacy standards. So you'll see PPs that, yes.
Oh, I just had one question. For the alternative access, could you describe the parameters when that might apply? Like, is that for rural counties or other particular situations?
Yeah, great question. So alternative access standards can apply in any county. It's interesting if you, like, for example, San Diego County, there are in highly urban areas, but also very rural areas as well. And you see that in most counties in the state. And even in Sacramento County, you're going to have alternative access standards. Really what that means is that the plan is not able to come into compliance because for a reason, there is not a provider available that can meet the standard that is set forth by the state. So an example might be that there's a provider, but maybe they're not able to come to an agreement with the provider, or maybe a provider just doesn't exist in that area. And because of that, then health plans are, or then because of that, then the health plan will ask for an alternative access standard and the state will grant one, basically saying, you don't have to meet the original standard, but here's the new standard that you have to meet instead. I hope that answers your question.
Yes, it
Okay.
does. Thanks for clarifying.
Perfect. So if you don't, as I was talking before, if you don't meet the requirements of network adequacy standards, you would be placed under a pass with conditions. And that essentially is a corrective action plan that requires you to do certain things. For example, here you can see on the screen that DHCS does require that each MCP provide out-of-network referrals and access and provide transportation if they don't have an approved network cert. And so that's important to know. If the plan does not come into compliance with the corrective action plan, then the state can impose financial sanctions and/or penalties. I don't believe that's happened with respect to network adequacy as of yet, but the state does have the ability to do that if they wish to. So just this goes through the list of kind of different things, and we'll go through these quickly in terms of the requirements. I know that Janine said you guys have talked about these before, but you'll see that there are different provider ratios that are required in terms of primary care providers per 2,000 members and physicians per 1,200 members. So these data are reported in the DHCS annual network cert that's linked on the slide here, and then also in the quarterly managed care performance dashboard. So you'll be able to find data related to both of these and by health plan, and in the geographic area, for example, in Sacramento County, on the DHCS website. Time and distance standards. You heard Janine kind of talk about the size of the county. So we've got rural, small, medium, and dense. There was lots of discussion about what kind of categories these should be when we first talked about what the standards should be. Ultimately, it was decided that we would have a dense county, and that means that you have greater than 600 people per square mile, which is what Sacramento is considered to be. And you can see that standards were comprised of the following provider types. So I think there are 8 that are listed here. An example is time and distance for a primary care appointment, where a provider must be available within 10 miles or 30 minutes of the member's residence. So again, whether or not the plan meets these standards in Sacramento County is included in the network certification standards that are submitted to CMS. And the standards themselves can be found in the all plan letter that's linked here, APL 21-006. Timely access. So DHC has put this on hold, but is picking this back up this year. This is essentially a secret shopper kind of campaign. So the ECRO, or the External Quality Review Organization that I mentioned, calls more than 30,000 providers across the state annually that fall into those 8 different categories that were on the slide before. For example, primary care specialists, ancillary services, and so on, and are asking, what's the wait time to the next available appointment? And then what's the wait time to the next 3 available appointments? And really the 3 available appointments is the best practice, and that's why that's asked, but the real requirement is tied to the wait time to the next appointment. And I think something that's important to point out is that while access needs to be available to a member within the plan network, it doesn't need to be to a specific provider. And I think that's just important to note, because sometimes people mix those things up. And so access within time and distance to a primary care doctor needs to be within the appropriate amount of time or distance from your house, but it doesn't need to be to a specific provider for timely access purposes. All right. So mandatory provider types, I think you guys are familiar with this, so just skimming through it really quickly. There are a number of different mandatory provider types that are included in the annual network cert that health plans are required to contract with. If they do not, then they are placed under corrective action plan as well. An example of that might be for Indian health facilities. While they are not required to contract with the plans are required to offer a contract to them. So there would be an example.
We did have a question in the chat from Jonathan Porteous.
Yes, hi Jonathan.
How often is the review performed? And in a delegated county like ours, all managed care beneficiaries care is delegated to IPAs except Kaiser. Can you say something about the network reviews at the delegated level? For example, frequency, level of detail, availability of caps, etc.
Yeah, so that's a great question, Jonathan. In terms of how often the network certifications are done, they are done at least annually. Now, that can get complicated because if there's a change in circumstance, so for example, many of you have been a part of it where a medical group closes down, for example, and so members are shifted from one medical group to another or something of that sort. That's a change in circumstance, and that has to be filed more regularly. But the larger network certification is done on an annual basis and is due July 1st to CMS. In terms of delegation, my understanding is that the state is now looking at delegation. And so they are, and this really kind of went back to when we implemented a program called Whole Child Model, which had to do with California Children's Services in Coast counties. There was a Coast County in particular where we needed to look at the delegated model specifically. And so we pulled down from the higher prime plan level and looked at the networks all the way down from top to bottom. And my understanding is the state is moving towards collecting and looking at that information now. And so I think COVID stalled it a little bit, but they're moving back into that direction. Okay. All right, so facility site reviews and medical record reviews. So this is really about making sure that the provider is in compliance with what the state and health plan requirements are. So before implementing or bringing a new provider on, or before implementing a plan implements, they have to go on site to all providers and do a facility site review to make sure that at a minimum, they meet certain standards and requirements. These are done every 3 years. Also, medical record reviews are done at that time. And that's an example of looking in the medical record review to see, like, was the initial health assessment done on time? Were vaccinations done? Other kinds of things such as that. So it's an opportunity to see if the providers are doing what the plans and the state have required them to do. And these data are collected and reported to DHCS. Interpreter services, I think you guys are familiar with. They are required by law and regulation. These are a part of the annual network cert review that is done. And so these data are included in that report as well.
One question for that that's come up before from the Consumer Protection Committee is the requirement for interpretation services that could be either telephonically or in person.
Yeah. So you just need to have access to it. It doesn't need to be, you can't mandate that it's like in person or something like that. You just have to have access to it. That's a good question.
Thanks for confirming.
Yeah. So I wanted to talk a little bit about the annual medical audits and surveys. And so all of the aforementioned areas are really encompassed into those audits and surveys. Though they're not considered kind of traditional data, they do provide a significant amount of information about overall MCP performance. And so I wanted to highlight them for you. MCPs themselves are audited by DHCS annually and by DMHC every 3 years. These are really an umbrella kind of oversight. So they're looking across the board at whether or not the plans are in compliance with either their DHCS to plan contract or their Knox-Keene license as applicable. In terms of, what they consist of, they have document reviews, verification studies, interviews with plan staff, among other things. And just noting that even though these are done annually by DHCS or every 3 years by DMHC, of course, they maintain the authority to go out at any time and do an audit or survey if they so choose, and if they feel there is an area of concern. This slide just really kind of shows you the different areas, the 6 different categories that are included in annual medical audits and surveys. So we have utilization management, case management and care coordination of care, access and availability, member rights, quality improvement, and then administrative and organizational capacity. And you'll see there are different layers within each of these in terms of things that are looked at. And I won't go too in depth into them, but this just gives you an idea of how big and how broad the audits are and what kind of information is collected from the health plans while they're being conducted. A couple of examples of annual audit findings that I just pulled from the website. So one being not attributed to any particular plan, but one being, that the plan would be required to provide non-emergency medical transportation and non-medical transportation services, and provide transportation for a parent or guardian when the member is a minor. So that's an example of something that the audit or survey might look at. Another having to do with health risk assessments and how often the health risk assessments have to be conducted, even though there's there's flexibility being provided right now for COVID-19, still that they have to be conducted within a certain number of days, and that's not happening. And so what happens as a result, these kinds of findings, is that the health plan is placed under a corrective action plan for any finding. And those documents, both the audits themselves and the corrective action plan documents, are posted here on the DHCS and the DMHC website. The one thing I would note is that the audits and surveys are only available by MCP and not by operating area. And so, for example, in Sacramento County, you would see that Kaiser is reported on, but Kaiser would also be representative of San Diego County as well. So a little bit about just how DHCS and DMHC use these data. And I think this is important to note because, for example, with the auto assignment incentive program, I'll talk a little bit about that. This is just an area where, even though the plans aren't reporting data, it is an opportunity for the plans to get more auto assignments, so they get more members assigned to them if members don't choose a health plan, but also just an opportunity for them to drive and focus on certain quality metrics that are associated with it. And so just a little bit of background in that the auto assignment incentive program, or the default algorithm, whichever you want to call it, was dates back to 2005. It's in non-COES counties, because in COES counties, you don't have any other health plan to compete with for assignment percentage. And as I mentioned, it is essentially assigning people who did not choose a health plan to a health plan in the county for assignment purposes. This slide here kind of shows you the three different components of the auto assignment and how it's calculated. You'll see that there are 6 different quality metrics that are included here. So cervical cancer screening, controlling high blood pressure, prenatal and postpartum care, and a few other metrics. Those measures are the 6 metrics that are calculated to come up with a certain number of points that are then incorporated into the calculation for determining what percentage the health plan actually receives of the auto assignment. There's also a focus on safety net measures. So you'll see here that the percentage of hospital discharges from disproportionate share hospital facilities is looked at, and the percentage of members assigned to PCPs, who are safety net providers, is also looked at in terms of calculating additional points for individuals that are additional points for the plans in terms of looking at what their overall performance is for the auto assignment. And then most recently, encounter data was added. And if you're high performing in terms of your overall encounter data performance, you can get an additional 6%. I think, let's see. Yeah, no, I didn't include that. I think in the future, we can talk about and look at what the percentages are for Sacramento County. One thing I would note is that not all health plans in Sacramento take default. Kaiser does not at this time take default. And so that means that the percentage that would have been assigned to them is reallocated to the other health plans in the county. The final thing I kind of wanted to talk about with respect to all this, kind of tying it together, are sanctions and penalties. It looks really big on this slide. Didn't mean it to be that big, but the point being that if plans don't come into compliance, then DHCS can impose sanctions and or penalties. A penalty might be something, for example, like they lose 10% of their default assignment, or they lose 25% of their default assignment. A sanction is obviously can be financial in nature, and those are posted on the website on the link here. And then finally, I just wanted to talk a little bit about the future. And so these are just a few of the things that I think we could talk about in terms of what's to come. So for example, DMHC has in AB 133, the budget bill this year, included information or included a requirement about a quality and health equity committee that would recommend measures and benchmarks to DMHC. And then DMHC is intended to identify specifically its own data set that it will hold plans accountable to. DHCS, my understanding, is including quality measures in their rate development methodology moving forward. Many of you have seen the DHCS community support / in lieu of services and enhanced care management incentive measures that are included in CalAIM. Also the population needs assessment, and then of course, ongoing data development and evolution. So I went through that really quickly. Let me just pause, see what kind of questions there are, or Janine or others, if there are things that I should focus on specifically.
Could, Janine, can we bring, stop the screen sharing and bring people
Yeah.
back?
How do I do that? Uh-oh. There we go. There we go.
Okay, great presentation. A lot of information, Sarah, but we appreciate
Yeah, it
your
was.
very thoughtful and patient walkthrough of all that information. I noticed, Janine, that I looked back into my documents. I don't believe I had Sarah's slide deck sent out to folks, but we would love to be able to do that. I know I'd love to receive a copy because I will need a tutorial on this from time to time because it's a lot of information. Good questions. So let's open it up for questions. Should anybody have any directly to Sarah? Floor is open.
Jonathan Porteous.
Yeah, I can't hear Sarah talk without bringing up the fact that every single one of us on this commission, every single beneficiary in Sacramento County has been touched by her. If it weren't for Sarah, we would never have adopted the whole person care program. Her patience and the state's patience in letting us muddle through and figure that out. We would never have had whole person care. We'd never have had health homes if it wouldn't have been for Sarah's patience and guidance. So we're all really indebted to you, Sarah, for that. And I just don't think many of my colleagues here realize just the role you played in that. And then just thank you for sharing the data. I didn't realize, so like drinking a bottle of Gatorade and realizing how thirsty you were. I didn't realize just how desperate I was to hear this again. We've talked about needing data and having you kind of point out where they are, and also some of the challenges. I think we're going to have disaggregating data, getting to certain levels, some of the strategies we're going to have to probably implement to get the information we need to even make wise decisions about 500,000 people on behalf of. It's daunting, and you kind of helped us see that and also gave me some hope that we can do it.
Well, thank you very much for your kind comments. And I only was able to do what I could do because I had the support of everyone here. So really, that's what I would say about that. But thank you. Thank you so much. All right.
Comment and feedback. I know that we were taking some questions in the chat as Sarah was presenting, but anything else from anyone? I'd like to think about in the future how we come back to some of this. I think it's a lot to digest in a single sitting. I know some of us are more familiar with it than others, but I think as we go forward to the next phases of this work, not that the first phase is complete, this conversation will become more and more important, and our ability to understand what's available, what isn't available, what gaps or holes it creates, and how we need to plan forward, I think will be heavily influenced by what I've learned today, at least my thinking, which clearly has to evolve. So if no additional questions for Sarah, Janine, do you have a question?
Oh, I see Ann Boynton's hand.
Ann, you have a screen.
Thank you, Sarah. Not a question for you, not to worry. Thank you for the presentation. It's very helpful. It did remind me, as you talked about, we can talk with DHCS about the potential of getting access to the data. They'll be giving us, in many instances, likely raw data. And we need to think about, as a commission, what do we do with that? Because we don't have the technical infrastructure to do the analytics now. And so there may be so thinking about what does that cost us as the county? How do we implement that? As well as, are there particular things that from the data that they're reporting to DHCS, we would, or DMHC, we would like as part of, we would like to ask the plans to separately provide to us under a confidentiality agreement so that we could access that data. So just a couple of points as we think further down the road about how we're going to really both get actionable data and then create the information that we need to be able to move forward.
Good comment, and one that's tied back to the issue around a budget, because what infrastructure do you need to build to carry this work forward? So just connect those two pieces as well. Other comments?
Siobhan.
Yeah, I was just going to mention, we have Sarah and her team on contract for the department. And so did intend to have Sarah continue to work with us, and we can maybe work through the quality assurance committee to come up with some recommendations as to how we look at this data moving forward. But I totally agree, Anne. It's either building the capacity or having contractors to be able to do that. Data crunch is going to be extremely important for us. Yeah. Thanks.
Other commissioners? I'm not seeing anything, Janine. Are you?
Nor am I. No.
All right. Sarah, one last thank you on behalf of the commission, and we look forward to continuing this partnership as we move forward. So thank you very much
Thank
for
you very
joining us.
much.